Good morning. We'll give it just a minute or two for people to sign on, and then we'll go ahead and get going.
Good morning.
Morning. Okie dokie. So while people are signing on, I can briefly, I love good morning people. So that just made me smile. So while everybody's signing on, I can give you the stats for exam one. You all actually did better than people typically do in exam one. So rock on for y'all. Sometimes there are many more people who fail. We only had a couple people fail. So the average score was a 79.97. So C plus B minus range. I usually try to aim for like a 75. So when you guys are above it, that means you're just smart. So rock on y'all. And then I'll do this real quick. I always like to give the distribution of grades. So how many people got each type of grade. So that's coming up now. So it kind of was like a normal curve, but around B instead of C, which again, I'm totally fine with. And like I said, as people get to know how I do exams, pretty typically they do better in this class. So if you weren't thrilled with your score this time, you know, please be heartened. They do tend to go up. If there's anything in particular you have questions about, please feel free to set up a meeting with me. Because of the way Blackboard does it, you don't get all the information you typically would were I to hand back a paper copy, right? So I'm glad to go over anything with anyone individually if you set up an appointment. So again, great job, first exam. We have a couple weeks till our next one. And again, these will now start focusing more on the disorders themselves. It's just sort of a reminder as we think ahead to the disorders themselves. You're now going to move with the Launchpad assignments from the video assignments to the clinical choices. So you will be in the position essentially of the intake interviewer for a client who has a problem related to that chapter. And your job is to try to figure out what diagnosis they should have. And you'll be asked other questions like what therapy should you give them, things along those lines. So please enjoy that. We worked really hard to make those fun for y'all and also to bring some accuracy and realism to them. Yeah. Any questions about logistics of things coming up? Oh, real quick, sorry. As you all are thinking about questions, if you have any, please stick them in the chat while I talk. I'm about halfway through figuring out group topics. If you have yet to turn in the topics you're interested in on Blackboard, please do so, if possible, by end of day today. If not, you'll get an email from me. There are, I think, 5 or so of you who didn't send them in. So, I mean, I can just like assign you, but I'd rather give you something you want to do. So go ahead and do that when you're able. There's a spot on Blackboard where you turn that in. So any other logistical issues, questions people have? All righty. Well, today we're going to finish up the lecture on mood disorders. And so Today we'll be talking more sort of like topically about this, sort of controversies within the field, other things beyond just the diagnosis. And then we will start in on our lecture about the treatments for mood disorders. And there's a whole chapter about treatments for mood disorders. And that's not the case for most of the disorders, partially because mood disorders are one of the things that we have researched the most in terms of how do we treat them. And there's a couple of reasons for that. One is, as we've talked about, these are among the most common disorders that people experience. Another is that there are just things that work really well for it, which is really great. For people who are struggling, there are lots of different options. But I think it's important before we get into that to touch base on some of these other things that you will run into if you're reading about mood disorders, or if I know some of you do have an interest in being clinicians down the road. As you go to diagnose people in the future, these things will come up. So the first is the specifiers, and I kind of alluded to this a little bit throughout our chapters. The idea that you have to indicate severity, but these have existed. Depression is actually one of the few disorders that even prior to the DSM-5, you did indicate how serious it was. You did give a rating of severity. So when I was in grad school in the mid to late aughts, I kind of hate that, the OOs, we were already diagnosing with this. So the first one is mild, or it's not severe. You have few, if any, symptoms in excess of essentially the minimum that you need to meet criteria. Again, in order to meet criteria for, say, major depressive disorder, you still need to have that minimum threshold. So someone could be experiencing a couple symptoms of depression, but not actually meet criteria for a depressive episode. And then again, not necessarily for depressive disorder. So these people will have impairment in their lives, but only mild impairment. Moderate is where this, I'm not even joking, this is like word for word for the DSM. The symptoms or functional impairment are between mild and severe. Super helpful, super specific. Right? But that is the actual definition in the DSM. And then you can have severe with or without psychotic features. Without psychotic features is sort of what we typically think of when we think of severe mood disorders. So the symptoms are in excess of what you need to make the diagnosis, and you have severe impairment in occupational functioning or social activities and or your relationships with others. Now, with psychotic features would be with delusions, which are fixed false beliefs, and or hallucinations. You don't need both. And hallucinations are sensory, so hearing, seeing, smelling, tasting, feeling something that isn't there. So the most typical one that I've heard about and actually experienced with at least one client was mood congruent. So mood congruent psychotic features they're consistent with the themes of the episode. So for depression, it'd be like guilt, disease, death, inadequacy. The client I had, when she had a depressive episode, would hear voices telling her to burn her arm in the oven. And for mania, it would be inflated worth, power, knowledge, identity, or having some special relationship to a famous person. I don't know his exact diagnosis, so I don't know if this actually applies, but this would be like John Hinckley Jr., which if you don't know his story, he's the man who tried to assassinate President Reagan. And he did so because he believed it would somehow get Jodie Foster to fall in love with him, right? So he could have had schizophrenia or a whole host of other things, but that would be the type of mood congruent, psychotic features you might have with a manic episode. Mood incongruent are you have psychotic features while you're having a depressive or a manic episode, but they're not really related, right? Like you might be hearing voices, but they're not like saying, you know, to harm yourself or you're a horrible person. You're just hearing voices, which is disturbing in and of itself, right? You also can specify whether it is in partial or full remission. Partial would be where you have symptoms present after you've met criteria for the mood disorder, but the full criteria are no longer met, and maybe you have a period without symptoms for 2 months. And then in full remission is you've had no signs or symptoms at all for the past 2 months. You can also have unspecified. This is used in cases where you need more information, like in the emergency room. You know, someone comes in, they're clearly having something going on. You can tell it's a mood episode, but you can't quite get all the information you need, maybe because of how the mood episode is manifesting. You can also specify the number of episodes for depression, so whether it is singular or recurrent. So, you know, major depressive episode, severe with psychotic features, you know, single episode. Sorry, it would be like major depressive disorder, single episode, severe with psychotic features. There we go. I'm a little rusty. It's been a while. It's like 2010 since I've diagnosed someone. Or, you know, recurrent would be if they've had multiple episodes of depression in the past. So then that might be major depressive disorder, recurrent, severe, without psychotic features. And then the type of current or most recent episode for your bipolar disorder. So you would indicate the most recent episode was manic, hypomanic, or depressive. There are other specifiers that come into play as well, just to give you even more information. So with these, you don't have to give one of these to everybody, but sometimes they are related and you want to indicate that. So with anxious distress is where you might feel keyed up or restless, having trouble concentrating, not because you're exhausted all the time, but because you're worried. Fearing that something awful will happen or that you might lose control. So it's essentially like you don't meet full criteria for an anxiety disorder, but you have some symptoms of an anxiety disorder with your mood disorder. Mixed features, and so this is, I think what I mentioned in passing last week, where there used to be a type of mood episode called a mixed episode. What chapter is this? Oh, Sophia, this is the end of the mood disorder chapter. And this might be an, okay, good. Let me know if it's not there, because I might have uploaded an old version of the slides. I did have to change them, obviously, if the DSM-5 came out. So if you can't find it, let me know. But this is, here, I can even tell you the slide number. This is slide 52. From that chapter. So mixed features are where you're meeting full criteria for, let's say, a manic episode or a hypomanic episode, but then you also are experiencing symptoms of a depressive episode. And again, this used to be its own separate type of episode, and then they took it away and made it this feature thing. And I'm not really sure why they made that decision, to be perfectly honest. But, you know, we can still acknowledge that this happens. I've certainly seen someone with mixed features before where she was manic, but then like would just start crying and like feel depressed, you know, a couple minutes later. And she had it with psychotic features in my mind, because she, I think I may have mentioned to you all in the past, she is the one who believed that God was speaking to her and telling her to cheat on her husband, which, like, no version of God that I know of says, like, go for adultery, right? So, and again, you know, who am I to, you know, question someone's religious experience, but it just seemed like she was experiencing something that was not quite religious and maybe psychotic, right? And if you meet full criteria for both a manic episode and a depressive episode at the same time, again, when we used to diagnose as a mixed episode, then now what they have you do is they diagnose the manic episode with mixed features because of the impairment and clinical severity of full mania. Again, if we think to that clip I showed of Richard Gere going and like spending all his money and being disruptive and things like that, and having sex with this woman he just met, it really is potentially very dangerous to you. And then to have a depressive episode with mixed features, again, you would have to have at least 3 symptoms of mania at the same time. And for any type of mixed feature episode, you do have to have it be observable by other people. So other people will notice, like, this person is acting manic, but then they, again, like, suddenly seem to feel depressed, or, are expressing feelings of worthlessness, things along those lines. Another specifier is with melancholic features, and this is for a depressive episode. And so this is more focused on that anhedonia, that loss of pleasure, loss of reactivity to pleasurable stimuli. These people tend to be more despondent, despairing, morose. Sometimes this is called like empty mood, where it's not even that they're sad, they just don't feel anything. Another feature of melancholic is early morning waking, and their depression is also worse in the morning. So something is, going on with those circadian rhythms for them. And everything else is typical of depression. So catatonia is something we typically see with schizophrenia, but you can experience catatonic features with a mood episode. So this would be like being in a stupor, so not responding to the environment at all. What's called catalepsy. So this is passive induction of a posture held against gravity. So they'll just like hold poses. And then what's also called waxy flexibility. So this really dates me, but to me, this is like a Gumby doll. If anyone had those growing up, or kind of like Play-Doh, maybe slime, I don't know. But it's like, if you go up to this person and you try to move their limbs, it's just like they'll just bend and they won't even respond to you doing it. Sometimes with catatonia, you have mutism, they're just not speaking. Negativism, so no response to instructions. Mannerism, where they're just sort of going through the motions or caricaturing normal actions. Sometimes there will be stereotypy, which is repetitive, non-goal-directed behaviors they'll just do over and over and over. You'll see agitation, grimacing, and then 2 things, again, that we'll talk about more when we get into schizophrenia, but echolalia, which is repeating what people say, literally like a parrot, right? And echopraxia, which is repeating what they do, so repeating people's movements. All right, so peripartum onset, we used to just call this postpartum onset, but again, having been through peripartum disorders myself, I've learned quite a bit about this. It can start during pregnancy or after delivery, and the reason they changed it in the DSM-5 is actually 50% of so-called postpartum episodes actually begin before delivery. And one thing I'll note is that this is like specific to mood disorders here, but there are a range of peripartum disorders. So there are people with peripartum anxiety. I had both depression and anxiety. I got the fun bag. Woohoo! But there are also people with like peripartum psychosis, for example. And really interestingly, close to us in University of North Carolina, there's actually one of the few inpatient hospitalization units in the country specifically focused on peripartum disorders. And then there's the seasonal pattern, which we talked about when we were talking about circadian rhythms. So this is a lifetime pattern regular seasonal pattern of at least one type of episode. Typically it's depression in the winter, although certainly it can be other things. And you have full remissions at another time of year. So in the summer, unless something horrible happens that's going to cause stress, you are not going to experience depression. And you have to have at least 2 years of this pattern in order to diagnose it. And it has to outnumber any non-seasonal episodes. If you like get depressed in the winter, but also every other time, right, you just have severe recurrent depression. Alrighty, so I mentioned previously that there are these gender disparities in the diagnosis of depression, and there are a whole host of reasons to try to explain this. And one thing I'll say is that this slide is not comprehensive. There are many other explanations. The other thing is absolutely none of the things that I'm going to talk about now explain it totally. So it's probably a combination of some or all of these, again, plus other theories that are out there. So artifact theory argues that women and men are probably equally prone to develop depression, but clinicians don't detect it in men. So men may not admit that they're feeling depressed or seek treatment, or they'll mask depression behind symptoms like substance abuse, essentially like self-medicating, or some sort of intermittent anger issue. Women display more emotional symptoms of depression, partially because that we are socialized that it's more acceptable for women to do so, right? And in actuality, what they found when they do research on this is women and men are about equally willing and able to come in for treatment. It's not like women have like great insight into their symptoms, and also they do present for treatment about the same. However, again, it might be that sometimes even if they're coming for treatment, that diagnosis is missed in the men. I will say, not only does being a woman not necessarily give you magical insight into your own symptoms, having a PhD in clinical psychology does not magically give you insight into your own symptoms. So when I was developing postpartum depression, I remember sitting on the couch crying at one point, talking to my parents who had come to visit, and I was like, I've got to watch myself for postpartum depression. And it's like, I look back on it and I was like, oh my God, like, how did all of your clinical skills turn off? But when you're the one experiencing it, that's what can happen. Hormone theory is that the idea that hormone changes might trigger depression in women. It's very unlikely that these are the sole reason. The thing that they try to explain this with is, puberty, pregnancy, and menopause are times when we see depression. However, those are all related to social stressors as well, right? So when you're going through puberty, you're usually in middle school, which like most people I talk to, that's the worst part of their lives, right? It's just everyone's mean to everybody else. Like it's just Mean Girls, but everybody. When you are pregnant or have given birth, your life drastically changes, right? So you have a new small being to keep alive. And menopause, you also could have some changes. Interestingly, like research is actually showing that a lot of women feel less depressed after menopause. It's almost like freeing. And obviously hormone theory has been criticized as sexist because it assumes that women's normal biology is flawed. Quality of life theory argues that women may experience more stress than men. And certainly if we take this intersectionally, you could see, women of color, women in poverty, women who are gender and sexual minorities, for example, having it even harder. So in general, women tend to experience higher levels of poverty, are employed in more menial jobs, have less adequate housing, and experience more discrimination, all of which in and of themselves are linked to higher levels of depression. However, and another thing they have is also disproportionate share of the responsibilities for what we sometimes call the second shift. So they come home from work and they're the ones cooking, cleaning, taking care of the kids. Now, this is certainly not the case in every family, and I think it's really changing with the millennials and the Gen Zers. Most of the families I know that are, I'm a leading edge millennial or a Oregon Trail, if you want to call us that, are much more egalitarian. But certainly this has historically been very true and is very true for a lot of families still. So there's probably something to this, but again, a lot of women experience that and not all women are depressed, right? So there's got to be something else going on. Social pressure theory talks about that women are taught to seek unrealistic body ideals. Actually, a lot of my research focuses on this with disordered eating, but certainly depression is related as well. So women are taught to seek low body weight and a slender body shape, and just literally not everyone's body can do that unless you do things that are very unhealthy for you. It's unreasonable, unhealthy, often unattainable. There are typically more lenient cultural standards for men. The example I always give is the show Modern Family, right? So the men on that show actually had some size diversity, but the women were all really slender. And it was just whether they were straight up and down slender or curvy slender, right? But certainly there are pressures from men as well in terms of the muscular ideal that's out there. So the other argument with the societal pressure theory is that gender differences and depressions first appeared during adolescence. And this is also where you start to sort of like notice things, your body changes, right? But some people argue that like focus on those things might actually be a result of depression rather than a cause. Lack of control theory argues that women may feel less control over their lives, particularly in Western culture, where, you know, we live within a patriarchy, right? Like absurd amount of our leaders are male, right? We've never had a female president. We do have a female vice president now, right? But our society is really geared towards men, and that has gotten better, but it's not perfect, right? So victimization of any kind leads to a sense of helplessness and symptoms of depression. And despite what you hear, and certainly I want to acknowledge that men are victims of abuse and assault, women have disproportionately higher rates of victimization, particularly of things like sexual assault and child abuse. So we hear a lot about young boys who are assaulted or abused. And I certainly, again, do not want to downplay that or downplay the gravity of it or what it does to them. But just think about that and multiply it by 6 to 10. And that's how many women and girls are affected by it, right? So we need to really keep that in mind. And there has been some research about women maybe being more prone to developing learned helplessness that we talked about, that Seligman did relate to depression. So maybe something there. There's also self-blame theory, which is that women are socialized to blame their failures on their lack of abilities and to attribute their successes to luck. And so this is linked to that like internal, external, attributional style that we talked about when we were talking about theories of depression. And this may not be as much of a problem today as it was in the past. So this is, again, one that certainly doesn't explain it all. A more modern theory that I think really started gaining a lot of support in the early 2000s is rumination theory. So rumination theory is a theory overall that's used to explain depression and anxiety. So this is the tendency to repeatedly focus on your feelings or your thoughts and just kind of think about them over and over and over when you're depressed or anxious. And you repeatedly consider the causes and consequences of depression. It's called rumination because ruminants, like cows, if you've ever heard of like a cow chewing its cud, what they do when they do that is they swallow and then they kind of regurgitate into their mouth and have to keep chewing or ruminating on the same thing in order to actually fully digest it. So kind of gross, but that's where the term comes from. So people who ruminate are more likely to become depressed and stay depressed longer. And in research, women are more likely to ruminate than men. So that may, again, contribute to a vulnerability to depression. Also, however, we have to think about the fact that that's correlational research, and it could just be that because women have higher levels of depression, they're more likely to ruminate, right? So we don't know causal there. Related to gender and depression. Those of you who've had me before have heard me rant about this. So this is my least favorite diagnosis that exists. It's PMDD, or premenstrual dysphoric disorder. So this was in the DSM-4 as a disorder for further study, and then they moved it to the main text of the DSM, so this does exist there. A lot of feminist researchers and theorists have a really hard time with this. There's a really great book about this and related things by an author called, she's Dr. Paula Kaplan, and it's called They Think You're Crazy, or They Say You're Crazy. And the idea is that this is supposed to be specifically for women who experience essentially mood episodes when they are on their menstrual cycle. And certainly there are a very small percentage of women who do experience things to the degree that like treatment will be helpful. However, as we go through this, you'll see that this could very easily be misused to pretty much diagnose anyone who has a period with PMDD. So that's where the problem comes in. So the majority of menstrual cycles, you have at least 5 symptoms in the week before the onset of menses, and then you start to improve a few days after the onset of your period, and then once your period is done, it becomes minimal or absent. So you have to have at least one of these top ones. So affective lability is just being moody. And again, it's supposed to be extreme, right, in order to diagnose someone with this. But again, you can see how in the hands of someone who's not educated in this, this could pretty much be any person with a period, because we all tend to get mood swings. Irritability or anger or interpersonal conflicts. Again, a lot of people with periods experience this. Here's where I think you again get to what this should actually focus on: the marked depressed mood, hopelessness, or marked anxiety or tension. And then you need to have one or more of the other symptoms. Again, remember, you do need 5 of these altogether. So anhedonia, that we've talked about a lot. So not having interest or pleasure in things, difficulty concentrating, and then you start to get into things that are just physical symptoms of having a period. So lethargy or lack of energy. Again, not everyone who experiences a period experiences this, but a lot of people do. Change in appetite or specific food cravings. This one gets me every time. It's like literally every person I know who has a period experiences these, right? And if you're looking at just, you need one of those from this list, right? Hypersomnia or insomnia, a sense of being overwhelmed or out of control, and physical symptoms such as breast tenderness or swelling, joint or muscle pain, and a sense of bloating or weight gain. Again, like a sense of bloating is just a symptom of having a period, right? Anyway, as you can see, I get really angry when I talk about this. You do need to have distress or interference, again, and there's a reason this was created, and it is, again, for those people with periods who it is so severe that they benefit from therapy or medication. So they have a diagnosis so they can get treated for that. I think they could have just been diagnosed with depression, right? Or another mood disorder. Paula Kaplan, when this first was proposed, came up with a great, I think she called it like intermittent rage personality disorder or something, but was essentially, she took like the male hormone cycle and made a disorder out of that. And the people at the DSM were like, I don't understand why you would try to pathologize men like this. It's just like, oh my God. Anyway, that is my mini rant. I will move on. This graphic shows a great relationship of all the factors that influence depression and mania. Again, Not something that you need to memorize, but certainly something that may be helpful to you as you kind of try to piece this all together. So let me go ahead and switch our PowerPoint to our one about treatment here. Let me switch my share. Okay. I'm getting better at this. I'm getting more seamless with the switches. So as I've mentioned, mood disorders are unfortunately pretty common. But the fortunate piece of that is that we've had a lot of people to study. So we've been able to find multiple types of therapy and medication that will help people with mood disorders. So more so for depression than mania, I think partially because of depression being that much more common, and partially because of how we talked about how biologically based bipolar disorder likely is, right? So treatments for mood disorders really are a good place to start talking about treatments in general, because mood disorders, again, particularly depression, respond very successfully to treatments. And there are many different types. So around half of people who do have major depressive disorder or persistent depressive disorder receive treatment from a mental health professional each year. In addition, many other people in therapy, even if they wouldn't be diagnosed with depression, experience depressed feelings as part of another disorder. So much of the therapy being done today at least partially focuses on symptoms of depression. It's really positive that we do have all these different types, because if something doesn't work for you, you can try something else. Different treatment types work better for different people. It also can be negative because of the competition among the methods. And one of the things that is related here is the idea that we now advertise medications, right? And sometimes those can be really confusing. So I think the first time I taught this class back in like 2006, I was flipping through a Time magazine, and there was an ad for mood stabilizer that just took the DSM criteria for bipolar disorder and were like, check these off and then take it to your doctor. And like, that's not how diagnosis works, right? It's potentially dangerous to, again, have people over pathologize themselves, not have a trained professional diagnosing. And again, the ads can be good too, right? Because the consumer knows what's out there and they can ask their doctor about it. But it's bad because most of the time there are no ads for therapy, right? The only exception I've seen is I have seen some ads for therapy for ADHD. But the vast majority of the time you're not seeing ads for like, do CBT or try this IPT. And most of the research that's out there suggests that therapy by itself or therapy in conjunction with medication is what works the best to treat these disorders. So to not have therapy out there as something that people sort of have in their mind could be potentially harmful to those individuals. All right, so depression. And treatments for depression fall into two categories, and each of these is going to have its own slide, so we'll talk about each in a lot more detail. But essentially, there are the psychological and the biological, and the sociocultural is just a subcategory of psychological. So we're going to talk about each of these in a lot more detail. So psychodynamic therapy, if you remember back to our theories, we're talking about Freud and his students. They believe that depression results from unconscious grief over real or imagined losses, and that can be compounded by excessive dependence on other people. So psychodynamic therapists seek to bring these issues into consciousness and work through them. Psychodynamic therapists will use the same basic procedures for all psychological disorders, such as free association, so having the person lie there and just kind of say what comes to their mind and follow that chain of thought. And then also therapist interpretation. So therapist interpretation can be of that free association, but also includes interpretation of dreams, interpretation of issues between the therapist and the client. So things like resistance to change within the client, or transference and countertransference. So it's a big piece of that. So despite successful case reports, researchers have found that long-term psychodynamic therapy is only occasionally helpful in the case of depression. And two features may be particularly limiting. The first is that depressed clients may just be too weary or passive to fully participate in these long clinical discussions. And depressed clients, kind of relatedly, may become discouraged and end treatment too early when it doesn't provide fast relief. There are brief psychodynamic therapies that, again, focus specifically on depression, and these have shown more effectiveness because they sort of eliminate those limitations. So there are some short-term dynamic therapies that work. I believe if you look on that Division 12 website I've shown you all a couple times, there are a couple dynamic therapies there. But again, they're going to be these short-term ones because people who are depressed need help right away, right? They need to start feeling better right away. And a lot of times that's why we end up combining medicine and therapy, is like the medicine will essentially give them like a jump start to be able to participate fully in therapy. All right, so behavioral therapy for depression is linked to Lewinson's ideas. And if you remember back, this ties mood to life rewards. And so he developed a behavioral treatment for depression in the 70s. And so he really argued you should reintroduce clients to pleasurable activities and events. So get them out there doing things. So we would often, assign them to go do something they like to do, right? Which sounds almost silly, but if you haven't been doing things you enjoy, it might actually be really hard for you to do that, right? And they will use a weekly schedule to introduce those. So what we would do is have clients complete a log for a week of just what they do. And then, we would start to introduce change and have them plan things that they could do that would be more pleasurable. This is often really eye-opening for clients, and they realize just how much of their time they spend in the throes of their depressive symptoms, right? Not being able to get off the couch, things like that. And that often motivates them to try to change. You also want to appropriately reinforce their depressive and non-depressive behaviors. So you want to ignore depressive behaviors and praise and reward constructive things they do. So if they bring back an activity log and it's like, well, I spend most of the week on the couch, you wouldn't focus on that as the therapist. You say, yeah, but look, you got yourself out to the Chrysler Museum, right? And that's a big deal for you because you had to go through a lot of steps to get there. So again, rewarding that. This could be thought of as conditional positive regard. So if you remember, Rogers has unconditional positive regard, but here Lewinson suggests that we want to only give positive regard in relation to things we want the client to keep doing. And you also, within behavioral therapies, will do social skills training. So helping them to be assertive, helping them to think about ways to interact with people in a healthy way. So there are limitations to behavioral therapy. There's really limited help from this when you're only using one of these techniques. When you combine 2 or 3 of them, as Lewinson had envisioned, the depressive symptoms do seem to be reduced. However, it's worth noting that Lewinson himself combined behavioral techniques with cognitive strategies in more recent years. And essentially, the idea has become that like doing this is good, but not enough. So this is your starting point. And in fact, when we talk about cognitive therapy for depression, the first 4 weeks of cognitive therapy are Lewinson's behavioral therapy for depression. And you can also do this in a group setting, which is sometimes really helpful because, again, they start to get social reinforcement for things. All right, so these are the 6 stages of change in behavioral therapy. So, sorry, I had this moment where I thought I was over time, but we have a half hour left. I apologize, y'all. It's like, wait, no, this class starts at 9:30, not 9. It's one of those little brain moments. All right, so there are 6 stages of change within behavioral therapy. So the first thing you're going to do is state the problem in behavioral terms. So again, it might be something like your behavior is that you are lying on the couch all the time. And what we want to change is getting you up and more active, you know, and again, not like exercising per se, although certainly that can be helpful, but just like getting up and doing things. Then you identify behavioral objectives, again, like getting up and doing things, especially whether you want the behavior to increase or decrease. So here we want to decrease the amount of time just laying on the couch, increase the amount of time, maybe, you know, again, taking a walk or interacting with friends over Zoom or in person if you're all vaccinated or can have mask and social distance. Then you develop or find existing measures and you take baseline measures. And you do this in order to determine whether change actually occurs. So it can be as simple as an activity log. It can be conducting naturalistic observations in session. There are different ways you can do this. But you need to be aware of the Heisenberg uncertainty principle when you do this. So this is from physics, and in the context of physics, it means you essentially can't know both the speed and the location of an electron at the same time, because in order to measure one, you change it, essentially. Same thing can happen here. You can't, essentially, the generally boils down to you can't study something without changing it. So as I mentioned, people doing those activity logs might start to change their behavior, or at least notice patterns in their behavior, even before you tell them to. And this isn't bad, obviously, right? They can just start jumping ahead in therapy. That's great. But it's just something you need to be aware of as a therapist. Modifying existing contingencies. Again, the idea of reinforcing people for doing the things you want. So right now, you know, things you don't necessarily think about, you have to teach people. So like, we're teaching our daughter to make eye contact. She's only 2.5, so like she doesn't know that's a thing she's supposed to do, right? And her best reinforcer is just a high five. So whenever she, you know, makes eye contact with us when we're talking to her, we give her a high five. So, you know, probably not that type of reinforcer, but, you know, maybe you tell them, you know, if you get yourself to go out and do this thing, you know, then watch this show you've really been wanting to watch, or, you know, get yourself that food you've really been wanting to try. And then you monitor the results by continuing to measure them and charting the rates of responses. So we literally chart things in therapy and share that with our clients so they can see their progress, which is really helpful for them. All right, so I've mentioned cognitive therapy and how behavioral therapy is really integrated into it. So just as a reminder, Aaron Beck is the guy who developed cognitive therapy. History, again, is that he was a psychoanalyst, basically wanted to do research about why depressed people had dreams that were really negative about themselves. And the psychoanalysts were like, we don't want people who do research. So he was like, okay, I'll make my own thing. He's an MD, he's a psychiatrist. So for an MD to dedicate this much of their life to therapy is unfortunately unusual in this day and age. But he is actually the only MD who has been made a fellow of the American Psychological Association, which is for the people with PhDs and PsyDs, because he's essentially a psychologist at heart. We kind of claim him. So cognitive therapy and cognitive theory views depression as caused by, resulting from, a pattern of negative thinking that can be triggered by upsetting situations in the moment. So we've talked about that negative cognitive triad, so negatively viewing yourself, the world, and the future. And these sort of negative thoughts you have kind of reinforce this. And so you're constantly reinforcing yourself that, yep, the world's a horrible place and there's nothing we can do to change it, and I'm the worst part of it at all. So these biased views combine with theological thinking and produce what we call automatic thoughts. And these are thoughts we have that just pop up. You know, we're in a situation and they're just like, oh God, I could have done that better, right? And we kind of beat ourselves up with these. So Beck's cognitive therapy is the leading, and my notes here say the leading cognitive treatment for depression, but I would argue now it is the leading treatment for depression. So the VA has rolled this out and recommends using this for depression with any veteran who is diagnosed. It's very commonly used sort of, again, across the country. Certainly there are other things that work, but this is very prolific. But this therapy is designed to help clients recognize and change their negative cognitive processes. So those negative automatic thoughts, those maladaptive attitudes. And this approach follows 4 phases, and it's usually 20 sessions or less, which again, if we think about like how therapy used to be, and you just go for years and years and years, right? Versus 20 sessions. 20 sessions, if you're doing one a week, ends up being about 6 months, right? So that's fast for therapy. So as I mentioned, the first phase is Lewinson's behavioral therapy. You're increasing activities to try to elevate mood. The second part is challenging those automatic thoughts. So, you know, we do a lot of essentially almost like logic work with this, or science, you know, like what's the evidence against that? What's the evidence for that? You know, what would be the worst thing that could happen, and could you survive it? And another one is, what's the worst thing that could happen? What's the best thing that could happen? What is the most likely thing to happen, right? And then my favorite probably is, if your friend was saying that about themselves, what would you do? Because we, as a people, tend to be much more compassionate to other people than we are to ourselves. So we look at identifying these negative thinking and biases, getting at those deeper things. And so you really drill down to challenging and changing the primary attitudes, the negative cognitive triad, the things that are sometimes called core beliefs. So the idea is there's often 1 or 2 or just a few things that really define how you think about yourself. I'm bound to be alone. I am, you know, not intelligent. I'm bad at love, right? Or I am unworthy of love is another really common one. And so getting people to change those is tougher, but you build up to it in this therapy. Over the past decades, hundreds and hundreds of studies have shown that this works for depression. And honestly, cognitive therapy works for a lot of things. So the conference I go to each November is the Association for Behavioral and Cognitive Therapies. And it's just filled with research about how these therapies work, which is fantastic. Around 50 to 60% of clients show a near total elimination of symptoms that doesn't even necessarily happen when you're taking medication. And this treatment can also be used in group format. So here is an example of what that activity log might look like. So, you know, you have the person just sort of log again the first couple of weeks what they're doing. And this looks like a log where they've started to plan things. So on Wednesday, they're going to a museum. You know, maybe they're starting to do things like calling people, you know, and here's someone who looks like a crafter. So on Wednesday evening, they're going to work on a rug, right? So incorporating all of these things, you know, and even things like scheduling when you're going to clean a room of your house. And this can be really helpful because people start to get stuff done. And then what we find is as people go out and do things they enjoy, their symptoms of depression start decreasing because they're experiencing joy, right? Again, it's not going to make them go away on its own, but it certainly starts to help. All right, this is what a thought record looks like. And so this is used for that second phase of therapy when you're challenging automatic thoughts. And so the way that you do this is you have them start by just talking about the situation. So what is going on? What sort of set off this moment that you had? And the one that we commonly use as an example to teach this is, let's say you're walking down the street and you see someone you know, and you wave and you yell hi, and they don't say anything, and they don't even look at you, right? And the way we start this is actually just sort of focusing on these three columns. So the situation, your thoughts, and the outcome. Okay, and typically people can't think about this column. People just think that because that person didn't wave to me, this happened, right? So, you know, what are some of the emotions you might experience? Let's start with that. Or things you might do if someone you knew didn't say hi to you. And you can either unmute or throw these in the chat. So you're walking down the street, you see a good friend, you wave hi, they just completely ignore you. How are you going to feel?
If we're good friends, I'm gonna assume they didn't see me, because why would they do that?
Right, right. Yeah, confused, someone else is saying. Yeah, so you might feel a whole host of different things, right? And what cognitive therapy gets at is, you know, kind of what Romina hinted at, right? That it depends on what you tell yourself in that moment, right? So you might be confused if you're like, but they usually say hi, like what's going on with them, right? Or if you're like, they must have just not seen me, then you probably feel like, okay. But what if you're in a depressed state of mind and the thought that you have is, well, obviously they didn't bother to wait because I'm just not worth it, right? Then you're going to feel even more depressed, right? You're going to feel overwhelmed. You might go home and just, again, not do anything productive you plan to do that day. So you would sort of think about the emotions and then think about your automatic thoughts. And then what we work on is trying to come up with a rational response to that, right? So is it that they didn't see you, do you think? Or is it that they are truly just not caring you're there, right? What's the most likely situation? And then they have to sort of rate things. And then after they come up with a rational response, then they sort of say, okay, well, maybe I don't, agree with what I originally thought that much. But the point is, essentially, as humans, we think like, I was in a situation and this happened as a result. And we don't think about that piece in between the thought that we had that made us think that way, right? I mean, I've even had people when I do this activity with them say like, I would be mad because I would think like, what did I do to them, right? And that might lead to some consequences like a fight. So, it really is these thoughts, your interpretation of the situation that affect your emotions, that affect the outcome. All right, so this is the cognitive theory of depression sort of mapped out. The idea is there's likely early experiences you had that fed into this formation of dysfunctional assumptions and beliefs. This might be trauma in your childhood. It might just be criticism and rejection. Could be from parents, could be from other kids, right? And that leads to your dysfunctional assumptions and beliefs. And then you might have a critical incident occur. So, maybe rejection by a significant other, something along, you lose your job, and that can trigger the dysfunctional assumptions. And that leads to negative automatic thoughts in the vein of that negative triad, right? The world is awful, there's nothing I can do about it, and I'm the worst part of it. So self, the world, and the future. And these negative automatic thoughts then essentially form a feedback loop with symptoms of depression, because you have behavioral symptoms like not getting up off the couch. So then your negative automatic thought is, gosh, I'm so lazy. Who would want to be with a lump like me? Cognitive things, again, those negative automatic thoughts feeding in. Affective, the emotions you're experiencing. Physical things, again, those physical symptoms of depression where you eat more and then you might berate yourself for that. And then motivational, you don't feel like doing anything, so you don't get stuff done. And then you're like, well, I'm useless, right? So here's what we really aim for in cognitive therapy, trying to get the client to be aware of those thoughts, those negative automatic thoughts they're telling themselves, they're beating themselves up, right? So this is the what. You become aware of what you're thinking. You start to recognize your own cognitive distortions or negative automatic thoughts, and that's the how. You start to learn to recognize where those occur, where those are in your life, and you start to substitute accurate for inaccurate thoughts. And this is actually a really important piece of this, is that it is accurate thoughts. It's not positive thoughts. It's not the world is rosy. It's let's be more realistic. So like one of the clips that I often show that I might just try to find on YouTube in a couple minutes here, because my CD player doesn't want to talk to my computer at all. But is Aaron Beck talking to a woman with depression whose husband has left her, and she just talks about like, I never expected this to happen, like how could this have happened? And he was like, is that a realistic expectation given the divorce rates, right? So he's not like, oh, of course it was going to work out. But it's just, again, about like being realistic about, sometimes we are too hard on ourselves, too unrealistic about our expectations. The client also gets feedback from other people as to whether the changes they're doing are correct. This could be other people in their lives. This could be the therapist. Then you engage in cognitive restructuring, which is what we just talked through with the thought record. So what's the evidence for that? What's another way of looking at it? So what if that happened? Could you survive it? Would it be that bad? And then you use what's called the as if method. And this is acting as if you don't have depression. And sometimes this is just called fake it till you make it. This dates back to Alfred Adler, who was a psychodynamic theorist. He's the one who first kind of came up with this idea. And so he came up with the idea that like, let's practice, let's try looking at doing something. So like you don't feel not depressed yet, that's okay. We're gonna go out and act as if you're not depressed. And what happens if you do that? Well, you might start to experience some pleasurable experiences, and you might start to actually feel better. Let me see. So we've got him talking about therapy. Aha, I found it. Okay, so I'm going to do a new share. I should just like go through and put these links in at some point. Alrighty, of YouTube, and make sure the sound's on for y'all. Alrighty, so this is him working with the depressed clients.
But first, what we want to do is look at exactly what you have lost. Now that the worst has happened, you're afraid that David was going to leave you, and he has left you. and you feel as though there's been such a terrible loss, it's like a guillotine coming down on you. So let's see, in actuality, what you have lost in losing David.
I lost my best friend in the whole world.
Okay. You lost your best friend. What else?
I lost having him to talk to about all my feelings and thoughts. Although half the time he didn't want to listen to them, but he still listens sometimes.
Well, half the time he did not even listen.
No, we just walk out of the room. You know that, we've been through that before.
Right. What else have you lost?
Well, I'm not sure yet in terms of, I don't know, financial support, moral support. I've lost the father of my children. I'm scared for my children not having a father now. I've read about what happens to kids when their parents split up, and I've lost that. I've lost my security. You know, I haven't been out working for years, and I don't know what I'm gonna do. David's being such a bastard about money now. Like he makes a lot of money, but I think he's trying to work it out that I just get some sort of minimum thing. I don't know what he's doing. Well, I haven't gotten anything from him since he left, and it's been a month now. And I'm really worried about money. I don't know what I'm gonna do. I don't have any income. I've got 2 kids.
Well, what is the thing that hurts you the most? Is it the money?
No. It's losing him.
Uh-huh. Now, do you think the loss of David is hurting more because of the symbolic meaning of the loss, or for what's been taken away from you?
I don't know which is more. It's probably both. Maybe it's more symbolic. I don't know. Maybe it's more all my hopes that everything was going to work out, that maybe it's losing my hope because I just kept hoping it would be okay. So maybe it is more symbolic than real. But it's still pretty depressing when you don't have any more hope, you know?
Well, it depends upon what your hopes are for.
Well, I hoped it was going to work out okay with us.
Right. So that's one hope that vanished. But aren't there other hopes that can come in and take their places?
I guess I'm not letting them come in.
You're not letting any hopes come in. In other words, when you look to the future, you're not even trying to think of ways in which losing David can be compensated for.
Who would want me?
That's all right.
Let me switch our share back to our PowerPoint here. So you heard, her, I think, really getting close to a core belief there at the end, right? Who would want me? I'm unlovable. And you saw, Ernbeck trying to help her think through everything, like what is actually getting at this for you. I wish that the other half of this video was posted online because she actually is, like they start joking together and whatnot, which is kind of nice. So actually, let me check one thing. I might have the video here. just a second here. Okay, yeah, I found another clip. Hopefully it's the one I'm thinking of. So give me just a second so I can screen share this with y'all.
All right, now, suppose David went away. There was a war going on, and he went away for an indeterminate period of time. In fact, you wouldn't even know whether he was coming back, as happened during World War II. Husbands went off, and nobody ever knew when the war would be over. They're gone indefinitely. And in many cases, indeed, the husbands did not come back. Now, if you were in that position of having lost David through his going back, do you think you would feel depressed the way you do now?
No. I mean, I think I would miss him. Because I would know that he would be wanting to be with me, but David's saying he doesn't want to be with me. That's different, you know, that's different. Like if it's a war, then it's not like David isn't making that decision. The government is making that decision. Okay. You see what I mean?
Exactly.
It's not the same thing.
Exactly. You're absolutely right. You see, at first it looks as though your big problem is the loss. You've lost your best friend, you lost somebody to sleep with, to hold you. You lost somebody to talk to, and somebody to love. And yet when we say, this could happen if he went into the service for an indeterminate period of time, you'd say, well, you'd miss him, but you wouldn't get depressed. So it isn't simply a matter of you not having somebody to talk to or somebody to love. The thing that's getting you down is the fact that he chose it this way.
Yeah, he rejected me.
All right. So David rejected the meaning of that to you. David rejected me.
He doesn't love me.
Okay, David doesn't love me.
I'm not lovable.
Uh-huh. You really believe that?
I don't know.
Anyhow, you've had that thought, I'm not lovable? So David is a supreme arbiter of who's lovable in this world and who isn't. Is that correct?
That really sounds dumb when you say it.
So if David said he didn't love me, I should go into an acute depression.
Don't make me laugh when I'm crying, Doctor.
Sorry, but...
So here you see the use of humor in session, which a lot of therapists use. Beck and Ellis, who also developed therapies similar to this, both really like to use humor. So I'm just going to let this play for another minute or so you get more of a feeling of what a session's like. I guess he's not the supreme arbiter of who's lovable and who isn't. Is there any reason why we should trust his judgment? I mean, you said that he was acting peculiarly. He talks about a commitment, 3-month commitment, 6-month commitment, on and off. To you, does that sound like a person who's exercising judgment? Wife, 2 children, start setting time limits to the marriage?
I don't know.
So here you have a person who, for quite a while, was leading you on to believe that he was faithful, and he really wasn't.
Well, we don't know that, but I suspect strongly that he wasn't.
Who indeed, you do know for a fact that he broke a lot of the promises that he made to you, and he's on and off 3 months.
So again, here you can see they're really working through challenging these ideas that what David does should control her, essentially, and that somehow this was her fault. And just sort of pointing out that he bears some responsibility too, right? So we'll stop there for today. We'll pick up with IPT, interpersonal therapy, on Thursday. So I will see you all then, and I'll do my normal hanging out for a couple minutes in case anyone does have questions.